Hello everyone, welcome to the video course Class Flip and Palate Week 7. My name is Hafsa Widyaningtyas, and in this video I will talk about what I get from this week. There are 5 topics in week 7. First is assessment of PPD. The second topic is the impact of cleft palate on speech. The third topic is cleft speech therapy. The fourth topic is management of newborns with cleft during COVID-19. And the last topic is multidisciplinary team approach to cleft care. The first topic is assessment of PPD velopharyngeal distinctions. Terminology of PPD, there are 3. Velopharyngeal insufficiency caused by anatomical abnormality like cleft palate, and then there are velopharyngeal incompetence caused by abnormal functions of the elements of PPS, and velopharyngeal mislearning caused by abnormal functioning the elements of PPS. Velopharyngeal dysfunction is failure of velopharyngeal sphincter at an appropriate moment. Effect of PPD on speech, there are hypernasality, nasal emission, weak or omitted consonants, substitution or compensatory articulation, and abnormal resonance. Assessments of PPD, clinical evaluation, subjective or perceptual evaluation, and objective or diagnostic instrumentation. And in the second topic, the impact of cleft palate on speech. Children born with cleft lip and palate can experience a complex range of challenge with speech. Babies with unrepaired cleft experience delays in consonant development, and then babies with cleft show delays in onset of canonical babbling and often produce fewer variety of consonants during babbling. Delays may lead to difficulties in expressive vocabularies, although some manage to catch up to their non-cleft peers in phonological ability by preschool years. Presence of other congenital anomalies, age of surgery, and middle ear disease can impact further on some children with cleft palate, resulting in significant delays and deviant misarticulation. The presence of cleft lip and palate can interfere with normal parent-child interaction. VPI has impact on resonance, articulation, and phonation, all of which alters speech render. Much of the individual speech difficulties has its basis in the early years of speech development, and last, early intervention can help correct much of this challenge. Okay, next we go to the third topic, we will discuss about cleft speech therapy. Cleft speech therapy has grown significantly from being a circumstantial vocation 2 decades ago to becoming an essential profession in the modern days. It began as a response to a demand for a docile, efficient, and dose productive speech, and now become more central to the industrial and democratic operation of modern society. Goals of cleft speech therapy. A major speech challenge of cleft patients are absence of quality voicing and improper articulation. B. The goals of cleft speech therapy should therefore include ensuring production of quality speech through the creation of new motor speech patterns that replace speech sound errors and initiating correct articulation. C. On a larger consideration, objective of CLT include improving verbal and nonverbal media of communication, promoting self-esteem, human dignity, achieving clear, flawless, and pleasant speech so that the speaker is well understood by audience, eliminating frustration, avoidance, and other psychological upsets common with speech disorder patients, reducing health risks associated with traumatic communication handicaps, and facilitating self-actualization productivity when effective speaking becomes an asset for realizing life goals. In the fourth topic, we will discuss about management of newborns with cleft during COVID-19. We need to improve the prenatal diagnosis of cleft. The birth of the baby should be one of the family happiest memories. One advantage of knowing the cleft diagnosis prenatally is that it provides the opportunity to ensure a positive birth experience. Despite the pandemic of COVID-19, the parents must receive the necessary information and psychological support they need. Less than 1% of the cases of SARS-CoV-2 are under 10 years old, and newborns with cleft and palate must continue to be seen in consultation with respect of all security measures in order to give psychological support to the parents and advice for nutrition before surgery. And in the last topic from this week is multidisciplinary team approach to cleft care. Team structure. First, the typical cleft or craniofacial teams include medical, surgical, speech, psychosocial, and dental professionals. One approach to team care involves separate assessment by a series of experts who plan treatment independently. This usually happens when they are apart geographically. Another approach has assessment by whole team, a common treatment plan, the opportunity to learn about other disciplines. In either case, regular team meetings to discuss the patients are essential. Recommend team member, orthodontist, speech therapist, nutritionist, audiologist, geneticist, anesthesiologist, data manager, pediatrician, surgeon, psychologist, ENT, parent or child, nurses, and coordinators. Conclusion: the cleft or craniofacial team is a means of organizing complex multi-specialty care in a humanistic and cost-effective manner. The team approach reduces costs, minimizes school and work time loss, and promotes a more comprehensive view of care. It implies quality peer review on a continuous basis. Constructing the most effective team possible is a challenge, but the rewards lie in the shared group interaction, the bonding, and the satisfied families and patients. Okay, that's all for me. Thank you for your attention. See you.